Thank you for inviting me. My name is Wael Agur. I'm a consultant urogynecologist working in Scotland, and I would like to thank you for giving me the opportunity to provide evidence today. And also thank you for suspending these procedures after meeting with the mesh injured women. I would like the review to know that you cannot meet all the mesh injured women, because there are women out there who do not know that they had mesh procedures. There are women out there who had mesh procedures but do not link it to their current problems, and there are women out there who know they had mesh procedure, they link it to the current problems, but they are too private to speak to your team. Also, it's important for the review to know that you have not met the majority of the people who receive these procedures and are absolutely happy with it. And that is the majority of the women who receive these procedures. So I'm a surgeon and a clinician and a researcher, and one of my duties is to reduce the risks of the treatment I'm providing, including the surgical procedures I perform. So it has been a learning process for myself and for many of my colleagues as well. I used to perform all transvaginal mesh procedures, and I used a variety of mesh devices during these procedures. I gradually stopped performing these procedures, or in other words, suspending these procedures in my own practice, with the realization that there are risks associated with these procedures using these devices that are largely out of my hands. So as a surgeon who perform continence procedures, it's my duty to reduce the risk, to mitigate the risk, to identify it, to prevent it, and to address it when it happens, and to reverse it as possible. And I've been largely successful in doing this with the non-mesh procedures, with the native tissue procedures. However, with the introduction of mesh procedures, and after a few years of doing these, I started to hear about complications that happen with my colleagues that I thought it's important to learn from. So rather than, well, life is too short to learn from your own mistakes, and you must learn from others. So I started to suspend these procedures in my own practice, because I thought the risk is or cannot be accurately predicted, cannot be prevented. It can be absolutely serious. It's a lifetime risk, it's a cumulative risk, and it cannot be reversed in the majority of women who develop it. And giving my opinion that this risk is avoidable because there are alternatives that are not associated with mesh-related complication, then in my opinion, most of my patients, this actually is an avoidable risk. So that was the main reason that I do not perform any procedures at all just now of the mesh type. So I continue to do the native tissue surgery or the non-mesh procedures. I'm also a researcher. I led some research groups into looking into mesh procedures and comparison with non-mesh procedures. And while there has been significant improvement in our understanding of the risks and the comparative risks between mesh and non-mesh procedures, I found serious shortcomings in the research, and I believe this is at least in part contributing to the perception of clinician of these adverse events, or we could say the significant difference in perception of these risks and their seriousness between the medical profession and the patient group and the public on the other side. So from the review of the literature, it was very clear to me that there has been a significant focus on short-term outcomes rather than long-term outcomes. There has been a focus on efficacy, on the success of treating incontinence rather than the adverse events. There has been some research or academic practices that are can be called outcome switching, where the researcher look at certain outcome. This has led, in my opinion, in confirmation bias, where the research team inadvertently wanted to reach an outcome that conforms with the current thinking or the direction of travel of everyone. Yes, there has been influence from industry. Sometimes it's declared, sometimes it's not declared, sometimes embarrassingly declared at a later stage. But what did really strikes me most in some of the publication I've read is the perception of the researchers or the authors of the reports of the pain itself. So you will find in the literature reports of research studies that describes there is chronic pain. So at 1 year, there is a percentage of chronic pain. So some studies say 1%, some say 2%, some say 3%. But you will find the conclusions that this procedure is safe, even though there are 2% or 3% of women who are suffering chronic pain at 1 year follow-up. So very, very little was done to find out what happened to those 2.5%, how much painkillers they are taking, how much impact on their quality of life, how much impact on their, if there is any disability. And I think because the risk is cumulative, we are now seeing these complications that were hinted at in the research a few years ago, but because there is no long-term evidence, the evidence only coming from patient campaigners and the society. Having said that, I strongly believe that the mesh procedures were not created equal. There are mesh procedures associated with much higher risks compared to others, and I put in my written evidence that there are perhaps 2 procedures that should be suspended or to continue with the suspension of these, and perhaps there are 2 procedures that needs to be restricted to situations where previous surgery using patients' own tissues were not successful, or if the patient cannot have the native tissue surgery. And the procedure also need to be restricted only to surgeons who can perform both mesh and non-mesh surgery for balance and for prevention of directive counseling, and to be performed only for patients who are fully informed of all the risks and their consequences. Thank you very much.
So can I ask you, and I would like to go into the conflicts of interest in a minute, but can I ask you the 2 procedures that you think should be suspended? Which are those?
So this is the transvaginal use of mesh for women suffering from pelvic organ prolapse.
Yes.
That's the first one. The second procedure is the transobturator tape for stress urinary incontinence.
Right, thank you very much. You talked a bit about conflicts of interest and the influence of industry, etc. Could you say a bit more about that? Who are they influencing and how?
So it takes several forms, and the medical device industry and the mesh manufacturers are not the only part of industry that is influencing medical research. So that also applies to pharmaceutical companies. So this is a wider picture of influence. So there are studies that have been solely 100% funded by industry, and there are studies that were partly funded by industry. There were studies where the researchers doing the research have competing interests with industry, or being personally and non-personally funded by industry, sometimes in relation to the project at hand and sometimes in relation to other projects. In one case that has been widely publicized, it was revealed that the manufacturer has actually reviewed the report before submission to the peer-reviewed journal, And in fact, it appears that the manufacturer did make some changes to the report before submission and before publication. That was not declared at the time, but it was declared a year, or I think maybe 2 years later.
Well, thank you for that. Have you any views about the regulator? Because clearly we need regulation in this, and whether you feel that's been adequate or whether you feel it should be strengthened?
The regulation must be strengthened. It was quite surprising to me how soon the mesh devices came to the market. I was not a urogynecologist when the first device came to the market, so I cannot tell you a lot about that. But I was a practicing independent urogynecologist in 2009, where there has been several mesh devices that is called TVT lookalikes and Me Too devices, where other manufacturers wanted to create competitors for their own device in the market. These devices were represented to us by medical reps as will do exactly the same as the previous devices. So this is an equivalence, but there is something that is additional. For example, it is less price, or it can give less complications. And it was quite surprising that how little research in quantity and quality was done before these devices were marketed. The regulators must do more to tighten the news around before approval of devices. There are steps going in the right direction in the States, but it appears that the European Union and the UK is a bit behind the FDA at the moment.
So strengthening the regulator would be to address this issue of equivalence.
Yes. And I think the FDA has proposed very recently to update the 510K process, where devices are approved on equivalence rather than they are its own merit. The famous example that we know, that the most commonly used or the prototype classic mesh device has been approved on the back of another device that was subsequently removed from the market, but the current one continues. So there is certainly problems with the regulation.
Thank you very much. So,
could you, it has been suggested to us that there are no circumstances where MES should be used because there's always a better alternative. Can you describe a patient in whom you would recommend mesh?
Okay, so again, mesh devices are different. There are some of them are associated with seriously high risk and almost no benefit or no benefit whatsoever. So I will answer your question 4 times. For the use of mesh in prolapse, I cannot see any circumstances that a woman would certainly require the use of mesh vaginally to correct prolapse rather than any other option. Right. So that's why this procedure is one of the procedures that I suggested that the suspension would continue. For the transobturator tape, it's very similar to the use of mesh for prolapse. The only what we could say an absolute indication to this procedure would be if there was a woman who had the very rare vascular graft procedure where there is a large vessel going behind the pubic bone. So she cannot have a Birch-Kolb suspension, a retropubic TVT, or an autologous fascia sling, because they all require going behind the pubic bone. So if there's a large vessel going there, then that would be a contraindication. However, there are still other procedures that can be done vaginally, for example, bulking agent injection. So that's why I suggested that the transobturator tape should not be used except in very rare exceptional circumstances. but I believe that the vascular surgeons have largely dropped this procedure in their practice anyway, so there will not be a lot of women with a retropubic big vessel. So that's why I believe the transfer should not be used, especially if it's associated with the highest risk of chronic pain of any continence procedure. So for the abdominal placement of mesh, yes, there is evidence that it is the procedure with the highest efficacy for prolapse, because it's abdominal and pulls the prolapsing organ right up through the abdomen. However, to me, it seems that the incremental benefit of reducing the recurrence rate does not justify going through the abdomen with all its associated risks, does not justify implanting a mesh device. However, there may be women who will have several vaginal procedures and they were not successful using native tissues, and in those women perhaps the only way forward would be to place mesh abdominally if they accept the risk compared to the recurrent prolapse they already have.
Would you do that as an open operation or a laparoscopic operation?
So there is no difference in efficacy, or there's no significant difference in efficacy between the open and the laparoscopic approach. However, the laparoscopic approach in the vast majority of situations require the insertion of a second medical device, which is a fastener to fix the mesh to the lower back. It is difficult to take a stitch in this area. It's a very strategic area, very, very difficult to take a stitch as we would do during the open procedure. So if laparoscopy is employed, then a second medical device is required. Sometimes this medical device added another layer of risk, which is disruption of the intervertebral disc and by inflammation and infection. For the last procedure, the retropubic tape, that was the classic TVT. That was the procedures that the vast majority of surgeons, gynecologists and urologists would say it's the gold standard, and it has replaced the colpus suspension, which is the previous native tissue gold standard. There are significant risks associated with it, but it appeared to be, it is not the worst offender. It is the mesh procedure that we could say that it is the mesh procedures with the least mesh-related risks. That does not mean it is safe. There are women who develop serious chronic pain and chronic problems with it. However, there will be women who have tried all other continence procedure using their own native tissues, and their incontinence is still persistent and very bothersome. And some of those women may opt to accept the serious risks associated with the TVT.
So it would be a last resort as far as you're concerned?
Exactly.
You go through all the other possibilities before that?
Yes. So I proposed in my written evidence that the retropubic procedures be used as a second-line surgical treatment. So the after conservative treatment does not work, the first-line surgical treatment for incontinence would be the native tissue surgery or the bulking agent injection. And if these don't work, then it would be the retropubic TVT procedure.
Okay.
Just to pick up on that point, so if the first-line surgical procedure fails, the native tissue first-line procedure fails, and you then resort to your second-line mesh procedure, does the fact that the first has failed in any way increase the risk of failure of the second-line treatment?
Yes. If the first procedure is a colpus suspension or an autologous sling, then the second procedure, inevitably, whatever it is, the risk of its success is lower than the quoted 85 to 90%. It will be probably in the range of 75 to 80%. However, if the first procedure is a bulking agent injection, then there is a consensus among surgeons that it does not compromise the patient chances of having the background success rate as everyone else.
So the success rate of the second line, the mesh procedure, is only marginally reduced. It's not substantially reduced. Did you say 85 to 80 or
yes.
90 to 80?
Yeah, and the same applies for a second native tissue surgery.
Yeah, okay.
So this is not something inherent to the mesh procedure.
Can I also ask a question about, you mentioned earlier that when you were doing transvaginal procedures with mesh, you used various different types of mesh, I think you said.
Correct.
Did you notice a difference in terms of risk of complication as between different types of mesh for the same procedure?
I did not do them enough to be confident to be able to confidently answer that question for you. However, I did move to from one device from a certain manufacturer to a different device from another manufacturer, hoping that I will get less complication, or my patient will have less complication, but that hasn't happened.
So to put it crudely, you wouldn't say there was a good mesh versus a bad mesh scenario?
They're all bad.
Right, thank you.
Yes. I wondered, you've obviously looked at the nice draft guidelines that have come out. So I was interested in your point about not using mesh for transvaginal prolapse. I've been looking at it, and my reading of it sort of suggests that currently we have a restriction that it can't be used unless it's for research trials. But that seems to have gone in the NICE guidelines, as if it's possible if you were not fitted or not suitable to have transabdominal, actually you may take the transvaginal approach, or that's what they seem to be recommending. I don't know whether you've read it in the same way.
I did read it in the same way, and I totally agree with you. I'm not sure how a committee of NICE reaches a conclusion that restricts a procedure to research only. However, another group within the same, under the same umbrella, reached the conclusion that it can be offered out with research. So I've seen that, and
what would you be saying?
I've already. What would I be saying to my own patients?
Or NICE, if you're responding, I don't know, to the draft guidelines. Have you sort of commented on that?
Yes. So we've sent comments on this, and we said that the recommendation from the Interventional Procedure Advisory Committee, IPAC, which was published on the 17th of December 2017, stands. And in my opinion, it should be restricted to research only. And in fact, it should be restricted full stop until we find out from the largest research study on prolapse that has completed 3 years ago, which is a prospect study. We should wait for the long-term outcome from this study before using any mesh, either within or out with research.
Okay, and that's now, how old is that study? And when are we likely to see the next one?
So the 2-year results were published in December 2016, and I believe the team now is preparing to publish the long-term results of the prospect study, I think the 5 or 6 year results.
So that's coming out quite soon, you think?
I don't think it will be in early 2019.
Okay.
But you could check with the team.
We will do. Thank you for that. Can I just go back? Obviously you had this sort of change of heart about how you used mesh, or decided not to. Are you alone in this? I mean, one doesn't get the sense that the rest of the profession sort of similarly took that view. So I'm just sort of wondering how that came about, that you observed and you heard and you learned from what you've been hearing, complication rates elsewhere, but the rest of the profession sort of took a different line. How do you explain that?
Well, that's the impression you get, and I understand that. However, there is an increasing number of surgeons who already stopped doing or using prolapse mesh and stopped using the transobturator tape even before I stopped. There are surgeons who never use prolapse mesh, and there are surgeons who never use the transobturator tape because they did not think it's a good idea at all. However, I think in my case, things were a bit different because I was part of an independent review, and that did not end up very well, and I had to resign from the committee, and then I had to express my views. Why did I resign from the committee? So, but I'm not alone in this. There are quite a large number of surgeons who stopped doing this, but perhaps they don't speak in public.
I suppose one of the issues is the sort of breakdown in relationship, if you like, between the medical professional on the one hand and the mesh injured community on the other. It has been, probably the relationship is at an all-time low. How one might repair that going forward?
We had that in the Scottish group, so there was a significant split, and we managed to, from 2014 and up until the second half of 2016, for 2 full years, we managed to get the mesh injured women, or the representative of the mesh injured women, and the representative from the clinical community, including the college and including clinical societies, managed to get them on the same table. And we managed to broker an agreement and published an interim report that everyone signed up to. And the Scottish report at the time, in October 2015, was the first authority in the whole world to express concerns about the transfer of tissue to tape. So the group was leading the world. I strongly believe if you bring a group of dedicated clinicians and mesh injured women around the table, look at the research, and with the perception of women who had good outcome and the women who had bad outcome, this is what we've done in Scotland. I think eventually the truth will come out and you will get everyone to agree on the way forward.
Thank you very much.
It was just a quick question. You supplied in your evidence the patient decision aid, which I thought was fantastic. How did that sort of develop, and how did it become implemented, and how widely used is it in Scotland?
So the idea of the decision aid came after the publication of the Scottish report in October 2015. It took us a few months to develop it. This development started with the local continence multidisciplinary team, so that involved physiotherapists, continence nurses, fellow surgeons. We also had significant help from an improvement advisor with Healthcare Improvement Scotland. We also had an academic from Glasgow School of Art to design the PDA for us. We started using it in September 2016. The theory behind it was patients are still not well informed even after they read the leaflet. Some patients do not want to read the extensive leaflet. I suppose the idea first came up during one of the Scottish Government meetings, where we said, okay, we've developed this information leaflet on mesh tapes. It's 24 pages long. Who's going to read it? It's just too long. Yes, it describes all the rest, but who's going to read it? So the idea was that we summarize the comparative benefits and risks of all the 4 procedures in one A4 page in a nice table that says that's the advantage, that's the disadvantage. So we've designed this. It took us a few months to design it. We've got version 1 out. We started piloting it in my local area. I spoke about it in national and international meetings, and every time I speak about it, lots of surgeons come to me and say, that's a great idea, could you please send us the link? My hospital published the patient decision aid on the website, I think that was September 2017, in all its nice and glossy format. I also run training courses for surgeons on native tissue surgery, and I always mention the PTA. So the form is being used in maybe 2 or 3 centres in Scotland, and perhaps, as far as I'm aware, maybe 6 or 7 centres in England. I did speak about the form in the Royal College during a meeting in the Royal College earlier this month. The Royal College is very enthusiastic about developing the patient decision aid, and I've been working with representatives from the Clinical Society and from the Royal College to develop version 2, which will be easier for patients to read and will have more explanation on risk and comparison of risk. So version 2 is expected to be published by the college soon.
Is it time?
Well, can I and then
Yeah.
come in? What you were saying at the very beginning is absolutely right, that we cannot see all the patients, and that some are too ill to visit us, others probably don't know they've had mesh inserted, others are very happy with the mesh and don't actually want to talk about it, and we absolutely understand that. I just want to ask you though, some of the patients we've met have been 70 years old, so that was, mesh started about 20 years ago, and so they are now 70 and really suffering from the mesh because things have happened to the product, as it were. And I just wondered if, in fact, this plastic that is introduced, is there a certainty that it will disintegrate? Is there a certainty that it will cause problems? Or can it actually be inserted and people be very happy with it till they die, and die perhaps in their 80s, 90s?
I wish I could answer that question. I cannot answer it with certainty, unfortunately. Having said that, I can only speak from my own personal experience, because the research is very deficient in this area. And there will be basic science research in what the mesh does in vivo, inside the human body, years and years later. But that's not my area of expertise. Having said that, I can tell you from my own experience, from my own clinical experience, not the lab experience, is that I have seen patients who had mesh for over 10 years, and they're coming to clinic with something completely unrelated to this. And I found this by chance only when reviewing the records that they did have a mesh procedure, but what they're presenting with has nothing to do whatsoever. I'm confident with that. And I've also seen some patients who had the mesh 10, 15 years and had been absolutely fine for 10, 15 years, and all of a sudden they are presenting with all sorts of problems that they are not just in their head, it is actually something physical. So I cannot tell 100% which one will have the best outcome and which one will have the worst outcome beyond a wheelchair. Because I cannot tell and I cannot reverse it, I stopped.
Right, well, thank you very much. Simon.
Can I just ask you about translational scans? Because in your evidence, in written evidence, you pose the question as to whether they are a useful investigation tool. Just wondered whether you had a view on that yourself that you could share with us, bearing in mind that, as we've heard, and no doubt you have, women often struggle to get access to an NHS translational scan, and they end up sometimes, in many cases, paying privately for a scan, which doesn't always help the diagnosis or decision making that follows. So, and bearing in mind also that there seems to be a disagreement within the clinical community about the usefulness of translational scans. So, what are your thoughts on the issue?
So yes, there is disagreement within the medical community about the usefulness of the translabial scan or the transperineal scan or whatever scan to find where the mesh is. Some clinicians do an MRI scan to try and find where the mesh is. So there has been effort to try and identify where it is before the surgeon goes in and takes it out. So I am not a mesh removal surgeon. I have not removed any mesh at all in the last at least 3-4 years. I did attempt, and some of the attempts were successful. Some others were not successful and required repeat. So I stopped. And when the national centres were recognised in Scotland, then I referred to the national centre in Scotland for mesh removal. So a woman who would require a translabial scan is a woman who is considering removal of the mesh. And the idea is to identify where the mesh is to guide the surgeon to remove it. It seems that there is agreement that, well, there's no agreement, but there is a view which I support, that it is not costly and it can show something that the surgeon did not know about and need to know about. One example for this is if the mesh device has been inserted in an unusual place, or if the mesh device has moved inside the body to an unusual place. However, surgeons who are experts in mesh removal and they have the documentation of the type of the device, they do an examination and they can feel the device, especially if it's eroded. There is no need for a scan. The other side of the argument is if the notes are not there, if the patient does not know how many mesh devices she had, then perhaps an ultrasound scan would be guidance. So patient selection is perhaps key. What is certainly needed is a pathway for treatment of women who develop mesh complication, to identify which one would require a translabial scan, which one. I think NICE, the draft guidance, has formulated a really very interesting table on what investigations are required and what the use are, but there is no stepwise direction. There is a meeting of the mesh removal surgeons next week, where I have no doubt that this issue will be discussed, which is how to create the pathway, which should be, I think, open for both the clinician and the patient. So the patients should read. I think the pathway should be written in a language that the patient understands, and that is along with a specific patient information leaflet. So we need a national information leaflet for women who suffers from mesh complications, and a very clear pathway to guide both clinicians and patients.
Dr. Gill, thank you so much for coming, and I'm sorry it's such a trial getting here, but we are delighted you managed to make it.
Yes.
And maybe we'll see you in Glasgow. So thank you very much.
Thank you.
Thank you very much for having us.
Thank you.